Welcome, everyone. Thanks so much for joining us for today's roundtable. Our discussion today centers on how AI is reshaping early disease detection, specifically for lung cancer. My name is Marilyn, and I'm on the product team here at Lucem Health. I'm excited to introduce our panelists today, who each bring a lot of experience and expertise to this space. Joining us today is Eran Choman. He's a Chief Clinical Research and Compliance Officer from our partners Medial EarlySign. Eran has been leading the charge to bring AI-driven insights to their clinical research efforts over at Medial EarlySign. We also have Dr. Coby Metzger, who is a data scientist at EarlySign as well, who brings a wealth of experience in data modeling and healthcare applications. Next, we have Dr. Ben Glicksberg, who is a chief data science advisor. His experience has been critical in translating complex data into actionable clinical tools to help improve patient care. Last but never least, Andre Peters, as Senior Manager of AI Solutions here at Lucem Health, is also with us today to discuss his work on operationalizing AI in real-world clinical settings. Thank you all for spending this time with us today. Before we dive in, I want to quickly define a few well-known terms you'll be hearing throughout the discussion, just for the sake of clarity. Artificial intelligence, AI, is more of an umbrella term that refers broadly to the process of giving computers a kind of intelligence, if you will, which allows them to perform tasks that usually require human decision-making. It covers everything from simple rule-based systems to really highly complex models as well. Within AI, though, we have machine learning, which you've all heard about, and this is where the system actually learns from patterns in the data. It is training a computer to recognize trends so that it can make predictions or recommendations on its own based on what it's seen before. Then there are the large language models, LLMs. You may recognize these from tools like ChatGPT and all the other chatbots out there. These models can process and generate human language, making them useful for conversational AI, but typically a little less relevant for clinical decision-making. Finally, you've all probably heard about generative AI as well. It's all the buzz in the media now. It's a type of AI that can create new content like text, images, even sounds, actually. And this can be really helpful in creative fields or in certain predictive tasks. In healthcare, though, we're usually focused on AI's role in making sense of complex data to support clinicians and other healthcare stakeholders. Today, we'll focus more on predictive analytics and clinical AI, the tools that are helping us identify patients' risk factors earlier. The goal here really is to improve outcomes by creating actionable insights that make the healthcare providers more proactive rather than reactive to patient care. As you all know, AI in healthcare, particularly in this early disease detection space and in predictive analytics, has become truly transformative in the last few years, both in diagnosing and treating disease. Lung cancer has become a prime focus due to its prevalence. And like all other cancers, early disease detection is really crucial to improving patient outcomes. So today, with the help of our esteemed panelists, we'll explore how AI-driven solutions are working to bridge the gap in screening, accessibility, and accuracy for lung cancer, and also explore the unique challenges and opportunities that is bringing to both healthcare providers and patients alike. All right, I'll stop talking now so you can hear from our panelists. To kick us off, Eran, could you tell us a little bit about the parthenogenesis and the incidences of lung cancer, and what about it really made it a good target for early disease detection using AI?
Thank you very much. Agree. I would start by giving some kind of a background about lung cancer. Currently, lung cancer is the leading mortality from cancer diseases worldwide. And as such, in the US specifically, the US Preventive Task Force, starting 2013, made a recommendation for yearly screening by doing a low-dose CT for ages 55 to 80 with 30 pack years history and current or either quit within the last 15 years as the screening target population. This criteria was updated on 2021 to include more patients due to the early onset of lung cancer, to include ages 50 to 80 with 20 pack years and current or quit within the 15 last years. The reason for that is most lung cancer are diagnosed at late stages, either stage 3 or stage 4, which decrease dramatically their quality of life as well as their life expectations. And mortality rate is quite high. Nonetheless, currently, the compliance rate in the US for lung cancer screening raise around single digits or low double digits, which means that most of potentially screened population is unscreened. So for us, the target population would be the entire unscreened population, which recreates about 90% of the entire eligible US population, currently estimated at around 15 million individuals. Having that number of potential lung cancer out there and the ability to provide some kind of solution that would be associated with early cancer stages or detection on early stages creates for us the opportunity to propose a solution that could support the screening compliance and the yield of low-dose CT as a screening methodology. So for us, that was the basic ground to do some kind of a proof of concept, whether we can contribute to such by providing an AI solution for that team.
Thanks for that. So AI isn't new as a concept. It's been around for years, definitely improving. The models and the technology is improving. What would you say has really changed in the last 5 to 10 years that makes it a more viable solution in healthcare now? Ben, do you want to kick us off with that?
Absolutely, and thank you again, Marilyn, for facilitating this conversation. As you had alluded to earlier, AI can mean a lot of different things to a lot of different people. And also AI in some form of or another has been around for quite some time. I mean, just the idea of learning from data is involved in a lot of like calculators and risk calculators that are still used today and have been developed 20 plus years ago for a variety of conditions. But there's definitely, as you alluded to, an increased pace that has been happening in the past 5 to 10 years, and there are many reasons for this that have made AI solutions more viable in the healthcare space. Viable is one word. There are many blockers that still exist, that limit full integration into clinical practice that I'm sure we're going to talk about. But there's been tremendous breakthroughs that are definitely starting to pave the way. I think, firstly, the most important thing are more and more patient data are being recorded and captured electronically. Electronic health records have been around for quite some time, but there's definitely more of a widespread use across both within the country and internationally. But also things like digital scans, pathology, x-rays, MRIs are being recorded, captured, stored electronically. And even things like mobile health apps, wearables, all these things can represent and capture some aspect of patient state and are being integrated into healthcare analytics. I think it goes without saying that there's also been pretty significant hardware improvements, GPUs, TPUs, both the hardware itself and also the number and availability and the magnitude of this hardware being used for modeling has been absolutely crucial for things like computer vision. You'd mentioned large language models. These are absolutely necessary and required to get it to the state that they're in. The algorithmic breakthroughs also kind of go hand in hand with these things. They've definitely been remarkable. I'm sure we'll be discussing more many of them today, so I don't want to go into too much detail. But like, for instance, the integration of LLMs into healthcare is particularly revolutionary, and we're just really starting to see its impact. Last but not least, I'll say that the other side of the coin, which has made AI solutions more viable, is increased attention from governmental regulatory bodies and just the idea of regulation in general. These bodies are thinking about this problem carefully and thoroughly, about how these models can be effectively tested and relegated into practice.
Right.
which in some ways represents a cultural shift towards the beginning of acceptance from the health system and healthcare space overall.
Thanks, Ben. Lots to unpack there. Let's start with the data itself, though. So let's say you want to create one for early disease detection, like the Reveal solution for lung cancer. You mentioned a lot of different data sets. There's structured data, there's unstructured data like notes, there are lab results, there's vitals, there's images, etc. So how do you go about selecting the right features, the right data, and kind of engineering that solution and ensuring that you actually have the right outcome?
I'm happy to kick that off, or if other panelists want to start, maybe I'll just quickly kick it off by saying I think there's it's a critical problem and a super important aspect of, even in the very beginning of the development process. I think there's really two schools of thoughts that represent the extremes, but of course the truth somewhere lies in the middle, where features can be identified by experts, like by expert clinicians or clinical practitioners that know of some inherent involvement of them within the disease diagnosis pathway. So, for instance, imaging is a crucial part of the diagnostic process. So, it's intuitive that we would want to include some form of that data into model building as well. Let me just go back to say that, on the other side, there's more of like an unsupervised approach where we can take all the all the data that's available and utilize methods to see what the models can learn from themselves that are important. And oftentimes what happens is it's somewhere in the middle that the true the ultimate model ends up being.
Makes sense. Anyone else? Eran, Coby, Andre, have anything to add to that?
I would talk some more about some hardships that you have with the medical data, as you are using usually retrospective data that you have in the database already, and you don't take new data in order to prepare these models, but you count on history data. The data is very asynchronic. Some patients have more of these labs, others have less of these labs. Some of them have it within a week before, and some of them have it within a year before. So you have to synchronize this data in order to be able to compare one patient to another. And in some techniques that we use, like taking some kind of statistics over the data that is engineered, not learned by the model, and then we create many features like this, like the mean in the last year, the last test, the last test a year before or so, and then we let the model just look for the correlations in the data and find among these many features the few features that are more important for the prediction and utilize them for the actual prediction of the model.
If I may add on my side, I think that we need first to focus on what would be the question that we're trying to answer. So what is the target, or what are we aiming for? Eventually, combined with the two answers provided before, you're looking for the most common information available in order to create that features, and that features should have some kind of clinical correlation to the problem that you're trying to predict. In sense, having the color of the eyes might be irrelevant, even though it might be very correlated. So in trying to explain what are the features that associated or contribute to the model, they should have some kind of logic behind it when we select those to start with. And eventually, it's also where you're trying to position yourself. For instance, whether you're going to be a diagnostic or screening or pre-screening, that would also dictate the features that you're using. Ben mentioned images. Images are part of the screening process or diagnosis process, which might be inappropriate to be used in a pre-screening process of trying to identify the elevated risk to start with. So I think that when taking into account all of the factors mentioned above, together with the practicality of what data would be mostly commonly used, that's another thing you should take into account when you try to build a predictor. Importantly mentioning, having a rule-based decision making is something that it's not new. I think it's been part of the common practice for over decades. I think that the ability of AI is to provide slightly better or more accurate predictor than already available methodologies that are out there. And one of the things that's changed throughout the years that people can start lean upon such models to be more accurate, but doing the same and not left as a black box if they can explain themselves what was the reasons or what are the features that are being used in that model.
Right, right. So we talked about a lot of the data here, especially with the model sometimes learning and identifying its own patterns and the mix of structured versus unstructured data. Andrea, I'm sure you see this a lot in your practical implementations of AI models. Can you tell us a little bit about how important and how you use true positive and true negative data, i.e., if you're doing something like a lung cancer model, you will need real lung cancer patients versus those who do not. And I'm sure there's, it runs the gamut in between. So can you explain how that is used and how the model is chosen to make sure that we're getting the right results?
Of course. So one of the saying within data science circles is garbage in, garbage out when referring to the data that goes into the model and the prediction that the model makes. So we try to improve the quality of the data as much as possible. And we are working with electronic health records, which are a representation of someone's health through the lens of their interactions with the clinical system, but it's not the most accurate representation of someone's health. And to that point, relying on codes for disease can be misleading in some cases. First of all, with a rare case could be of having a code for a disease when the disease does not exist. We call that coding pollution. So that would be a false positive in the record that we show the model as being a real cancer patient. And a false positive could happen for a number of reasons. Could be administrative error. It could be a code assigned during the screening process for lung cancer, but lung cancer was never found, or maybe the tumor was benign. Or it could be that the patient was diagnosed at one provider and then went on to receive treatment at a specialized cancer center. That's not truly a false positive, but we cannot ascertain its positive negative condition because we don't know what happened to the patient afterwards because they moved to a separate clinic. So we look at the pre-diagnosis and post-diagnosis pathways when we ascertain the disease and look where the patients screened for cancer. Do they have imaging? Do they have biopsy? And then post-diagnosis, did they receive treatment, chemotherapy, radiotherapy, medications for lung cancer in order to ascertain the true existence of lung cancer in the patient? On the flip side, there is a case of false negatives in the data set, and this is very salient for conditions that have an evolution that spans many years, or in some cases decades, which is the case for lung cancer. We can have a patient that looks healthy in the electronic health record because they were not screened for lung cancer. They don't have symptoms for lung cancer. So nobody knows that they are living with this disease at the moment. So whenever we look at the data, we try, especially in the pre-diagnosis part of the record, and in this case, diagnosis does not exist. So we look at the last few months to few years before the end of the record to see if we have any indications that a patient might be a positive in reality. So we look at benign tumors. We look at if they received any screenings. In which case, if the screening result was negative, we can have better ascertainment of the negative status. All that being said, it's a fairly meticulous and custom process for ascertaining the disease status, and we try to be extremely careful with this process in order to produce the best models and to have data for our partners like Medial EarlySign to validate the model performance in the most truthful manner.
That doesn't sound challenging at all. Anything to add there, Ben?
Yeah. Thanks, Marilyn. Andre definitely hit on, I would say, the most important points that make utilization of real-world data particularly challenging and beyond. I'll just add two quick aspects of flavor that perhaps showcases the further complexity of working with this data source. Depending on the disease, right? Depending on what we're interested in, what we're focused on. As Andre alluded to, the setup of electronic health records overall is not really for research. It's for operations and billing.
Mm-hmm.
And even the way in which diseases are recorded for operations and billing, such as diagnostic codes, are also not fully meant for research. So, for instance, if there's some subform of a disease or a disease that is relatively new in its discovery, there may not even be a diagnostic code for it. So the ability to really understand what this disease is separated out from a more large scale descriptor is very, very, very challenging. And there are some ways that we can get around that, but it's just something that's inherent in the data. Last small point that I'll make is just the need to be careful with some of these data sets, because a lot of times certain healthcare and hospital operations practices are built in or bleed into the system itself. So for instance, a certain hospital or health system in a certain region has probably a preferred diagnostic pathway of what is done for certain diseases, which may differ slightly from other health system practices. And therefore, the order of operations or order of data that are collected and the types of data are collected may be somewhat unique to that practice.
Mm-hmm.
So the kind of combination of both fuzzy labels, which Andre had alluded to, but also this inbuilt potential specificity bias that does not relate to biology, that relates to more of the operations aspect, make the creation of generalizable models quite challenging. That being said, I've been very negative about real-world data sets. I do want to emphasize that these are absolutely invaluable for the field. Particularly, I've been leveraging them or trying to leverage them for the past decade. So it really has unleashed data for model building that it was unprecedented before. So despite the challenges that I've been harping on, it's really an incredible source for projects such as these.
Absolutely. And I'm glad you talked about the generalizability. That brings me to my next question, because there are differences, not just in the operational way that the data is collected, but in the population's characteristics, etc. And so how do you conduct like any kind of validation studies? How do you ensure that your model really is generalizable to different populations in that way? Eran, do you want to kick us off with that one?
Sure. Just to start, I would say that there are two types of models: the one that continuously learning and the one that already being freezed and being introduced to different subsets. So our approach is to have a frozen model, and only after the finalization of development to introduce that to the validation process. Our first layer of validation would be on a blinded subset from the learning set that we used, which means that we divided randomly the population that we got for the training. We keep about 20 to 30% aside blinded. We develop the model, and then we try to see whether or how it predict on the remaining blinded subset that we left outside. And then we have a rule of at least 2 independent data set coming from different sources for another retrospective validation layers. And I think at that point, we feel comfortable enough if we can reproduce similar performance to introduce that model to be a product and to be introduced to real world data to support, which means that one of the downside of using retrospective validation is the observational and not the interventional part. And by having a prospective assessment, it allows us to see first how it works within the clinical pathway, but also to see the actual impact of individuals being in the process due to them being flagged by the model. So we start with at least 3 data set for retrospective validation, and then moving forward to prospective validations to support. And by that, we're providing both clinical evidence, but also the assurance for us that the model is ready to be introduced to multiple regions.
Makes sense. Thanks so much for that. To dig a little deeper on that, another consideration in healthcare, especially when using data to make important decisions, is equity. So how would you say what steps would you say you take to ensure like data fairness and equity within the model development itself?
Probably you may support my words, but in a sense, we're trying to introduce the performance of the model of subsets associated with subgroups such as sex and race to see whether we're performing similarly on the same positivity rates. And so having same sensitivity at the same specificity level, and that would provide us the feedback that the model should perform or very similar on different subpopulation. Very important for us. It's not part of, for instance, race is not part of the model itself. Nonetheless, it was important for us to test that, to demonstrate on evidence that performance are similar for those subset. Right. It could be a race associated, a sex associated, it could be even a BMI associated. So we're trying to provide an overview as much as we can on sufficient subset to demonstrate similar performance.
Mm-hmm. Ben, did you have anything to add to that?
Yeah, I think Eran spoke to it very well. I guess maybe just for some context that I can perhaps add, this idea of equity and fairness relates a lot to the biases that we had alluded to in this discussion before, both explicit. Certain people of certain backgrounds being treated differently based on practitioner-patient interactions, or based on insurance status, if you will, or even more implicit ones that just are inbuilt into the system of treatment. What it means is that when models is learned from these particular representations and situations, almost undoubtedly these aren't going to be generalizable. So this is something that in building retrospective models, so models that are just built on data and tested on data, it's of course important to assess for these things. But in order to really go beyond this, I think Eran alluded to the need for testing along different axes and different steps in the model development. In and of itself, a prospective validation is huge. It really differentiates, I would say, the vast majority of AI model projects and papers that exist, which are 100% limited into that retrospective data set space. So the ability of proper experimental setup on the retrospective data set, any kind of prospective validation, whether that's a silent pilot framework or it's an actual clinical trial, external validation on different systems, ideally a randomized control trial, but that of course is quite difficult. These are the types of things that I think are going to need to be done more and more throughout the life cycle of model development. It's not easy. It's not going to be easy, but we're seeing more and more that it's going to be very much necessary.
And I want to add to Ben's input that we strive to have equity in the model performance, but we also measure and strive to have equity in the delivery of care. So we measure parity amongst different groups as they interact with the healthcare system and as they receive treatment for the condition. So we can catch if the provider is showing bias towards screening particular groups versus others, say the non-insured group or the insured group, or particular ethnicities receive more or less screening and care. So we can tune the models, and we generally try to increase parity through AI rather than promote bias and disparities of care, regardless of the model performing in an unbiased manner, but also in providing a solution that promotes parity.
I like that, Andre. I don't know that I've heard a lot of discussion around using the AI itself to remove its own implicit biases. So thank you for that. That's a great point. So in the interest of
if I just may add, I think that Ben and Andre raised a very important issue of the bias associated with the training set or the validation set. So one of the things that we try to overcome is by having what would be considered to be a big data retrospective studies, which means that all of our validations are carried out in hundreds and thousands or even a million data sets in order to reduce the bias selection associated with using a retrospective data set. So for us, it's another way to assure that we are mostly representing the population we're trying to target eventually.
I would like to comment also that testing for equity is tricky because sometimes there is different incidence in different populations. And if you want to measure just the detection rate, maybe the detection rate will be different between populations. So you have to concentrate on indices that do not depend on the incidence, like sensitivity or specificity, but not predictive value or false positive rate or something like this. So you have to make sure that you measure the right thing. So if somebody is sick, you want him to be detected with the same probability, whatever population he is in. But the fact that you don't find many pregnancies among men doesn't mean that they are this is still equity. It's not a problem, and you have to measure the right parameters there.
That is a very great point, Coby. It's making sure that you're almost not creating issues by trying to be fair, right? And taking that to the extreme, to the point of the detriment of the people you're actually trying to help. So thank you for that. All right, so let's move on to the real world application of lung cancer itself. So want to talk a little bit about why lung cancer. What do we think are some of the clinical and financial benefits for lung cancer detection, specifically using AI? And Coby, I'd love if you start us off on this one.
First, lung cancer is a serious disease. It's a fatal disease with a high fatality rate. And there is already a screening program. And as Eran mentioned before, the compliance for this program is very low. at the moment. Now, if you want to put some effort on locating the patients, you would like to put it on the patients that are that have the highest probability to actually be sick and be found and not and have less futile tests. You have to remember also that the screening in lung cancer, which is low dose CT, is associated with radiation. So itself has a side complication, which is not really measured, but if you can somehow elevate the yield of the tests, it's better because then less people get radiation for nothing. And this is the reason we would like to have people with a high probability of being detected. And lung cancer is also have what we think good predictors in the data. First of them is smoking, of course, which is a very high predictor. The other one is age. And then we have some others in the lab data that can predict lung cancer. And not only that, some of them also predict other conditions that may imitate lung cancer. And therefore, if the model can eliminate those from the data, from the flagged people, the flagged population, then the performance is better. So it's achievable, it's paying, and it's saving lives. That's the main reason to do it.
If I may elaborate a little bit about the financial aspects.
Yeah.
Most screening programs struggle between the clinical impact and the financial impact. Either they're not financially benefit, but clinical impacts positive, or the other way around. From the work that we conducted and published, our budget impact models demonstrated that it's both clinical positive and financial positive, meaning you're dealing with early stages of lung cancer, which are much low cost to deal with or treat compared to the late stages. And by saying that, I would say that doing a budget impact modeling, I would say that within the second or third year, we're breaking even between the expenses and the cost saving associated. And ever since from the third year onward, we're making savings for the organization to use that modeling. The reason for that is that at the beginning, we identify a lot of early cancers, which are going to cost at the first few years, but eventually we're providing them the option to treat them in early stages, which are in lower cost, as opposed to being detected in 3 or 4 years from now in later stages, which are much more expensive for them to treat. So we're seeing both aspects of clinical impact of providing a tool to identify elevated risk population together with the option to early treat them, and for sure providing them a better quality of life because they are in a curable stage. And by doing that, we can provide both aspects of financial and clinical.
I would like to
Makes
add
sense. Yeah.
the dimension of indirect costs on top of Eran's comment. A majority of cancer is diagnosed in stage 3 and stage 4, where chances of 5-year survival range between 10 and 30%. Whereas stage 1 and stage 2 cancer, chance of survival is between 50 and 80%. So by shifting the diagnosis into stage 1 and stage 2, when the disease is curable, when the quality of life can be drastically improved, and when you can save so many lives, you create a huge impact on the quality of life, on the productivity of that individual, in their safe return into the workforce, and that is something that goes way beyond the clinical and financial aspects that we model for the provider, and create downstream benefits to society at large.
Absolutely. Yeah. That one is a little personal for me. My dad was diagnosed with stage 4 prostate cancer. It was, I think my sister called it stage 5. I didn't even know there was a stage 5 really, but it was pretty bad by the time it was caught. And my mom had cancer as well. And so this early disease detection work is just really personal for me. And I love how the models are getting better and better at detecting those stage 1s and stage 2s. Cancer is just, I don't know what's happening in the world, but cancer is just everywhere now. So thank you for that, Andre. When we talk about the health systems themselves, though, I love that we talked about both the clinical and the financial side. As you all know, selling into health systems is notoriously difficult now because providers have so much on their plates. And even though the solution is good and it will help and all of that, just the thought of adding something else to a provider's work stream is really hard, and it can be a hard sell. So making that clinical and financial argument, if you will, is definitely goes a long way to getting that in there. But how how is that working in the real world? Like when integrating these models into healthcare systems, how do we avoid kind of disrupting the clinical workflow and creating more work for the providers? In your experience, what are some of the ways we've mitigated some of these concerns I'm sure arise? Ben, anything to tell us?
Yeah. It's really interesting. So when we think about, or at least when I think about or have thought about model development, or really the model life cycle, it's really focused on the development side. Really everything that we've talked about before, all the challenges, and there are many, are like, what do we even need to do to build something that can classify, predict, etc. But there's the whole other side of the coin, right? Which is, how do we make that into a solution? How do we make that into something that actually affects care, affects patients? This example of the early detection is so key. But if we're unable to run an algorithm per se on one of these patients that could benefit, then it's really all for nothing, right? It's more of like a theoretical thought experiment. And Google medical AI plus lung cancer on PubMed or Google Scholar, you're going to get hundreds of thousands of results, of papers, of conference papers. But how do we actually make it to the next steps, or series of steps of getting them utilized and properly utilized? And this is like a whole separate field, or series of fields of like implementation science. How do we integrate something into a system without disrupting it? I mean, we think of healthcare, we think of processes, the diagnostic pathway. It's a very complex intersection of many different systems, many different individuals, different backgrounds, skill sets, expertise. And a lot of models just don't consider that. It's just the model itself. But there are many models that are, like, for instance, deployed and an alert is created. Okay, an alert is created. So who's seeing that alert? When does that alert come up? How is that alert displayed? Who does it go to? When does it go to that person? All those things matter, really, because like otherwise, another ding. Clinical practitioners are very busy. They have a lot going on, and if they get constant bombardment of alerts that have low specificity, then it's going to actually do the opposite. It's going to create an annoyance and something that they're actively not paying attention to. So, the way I think about it is, in order to really think of a solution, it's critical that buy-in, that there's buy-in from people, all the people that interact with this, right? From the model developer to the patient, to the healthcare provider, to administrative staff, to hospital operations. All these things, and even the delivery of that result. Individuals that are responsible for like software development is going to be key, because otherwise it's just going to mess up the care process instead of augmenting it.
I may add, Ben, to your words, I think that within Medial, we are having more than 10 years of experience of integrating models into healthcare systems. This is our fourth model being introduced. And I think in a sense, what we learn is there aren't two similar cases. There's very high level scheme that's very similar between, but the solution is more according to the clinical pathway of each and every potential customer. In a sense, the model should be integrated in a seamless way, both technically and clinically, which means that it doesn't create a new methodology of patient management, but rather, as Coby mentioned, you're having a screening program, we are integrated into that, and we're finding the right spot to provide our signals or our flags. So I think that both Lucem and Medial have the experience of providing a one-stop shop solution to provide such solution, to be integrated both technically and to provide some kind of clinical insight of how it could be easily implemented. And in a sense, developing the model is easy. Integrating that is the tough cookie around when we're trying to get there, because each and every organization has its own clinical pathway, decision-making, finding the right stakeholders, putting less efforts on the side of the customer, and mostly coming with our solution in hand to provide them some kind of easier way to implement that.
Makes
Like
sense. So go ahead.
There is an important cultural component in this, especially when you come to the patient. You could have the best model in the world. If the patient doesn't come for this, you did the pre-screening, but if the patient doesn't comply, doesn't come to the screening, then you did nothing. And invoking the cooperation of the patient is an art for itself. And we were involved in some works that we tried doing it by personal calling them, or sending an SMS mentioning that a computer decided that they should come, or the doctor recommends that they come. That depends from one place to another how people will respond to this kind. Some of them will look at phone calls as a disturbance of their life. Other people won't react to SMS and erase them immediately. So it depends to whom you are applying, and you have to be very sensitive to the cultural nature of your community when you implement such a mechanism.
You know, Coby, you and Eran touched on such important points here. You know, we think about like personalized medicine, really from the treatment side, but you're totally right. Like the societal construct of it is almost equally as important. And I think you hit on the right point, right? Like a one-size-fits-all solution is not going to be it. And actually doing, even if it's just pilot studies, small-scale studies on how these things can be, you know, how we can interact with patients on the proper delivery of these screening algorithms, for instance, is going to be equally as critical. And I hate to use this phrase, but really it's like each solution is going to require both a bespoke model, but also a bespoke implementation for each site, perhaps, where it's being implemented in.
Right, that makes so much sense. And your model has been in place for several years now, and you touched on some of these insights and some of these learnings. Just wanted to hear from you, Coby and Eran, a little bit more about what else have you learned as you've been operationalizing these AI models in the real world, and how has the model evolved over time and incorporated some of these new insights and learnings?
One of the things that we learned is that since we're providing some kind of decision support tool for healthcare professionals to make decisions, we need to make it as clear as possible. For instance, it shouldn't be a black box, just this individual is in high risk. So for that purposes, we created some kind of additional information, which we called explainability, that explain why a specific individual, based on his or her personal health records, was the reason for them to being flagged. When a doctor is looking into both the flag and the reason for that, it can correlate to what would be the reasons that would be associated with elevated risk for specific individuals. So we're providing some kind of opening the box to get better insight of why the model flagged a specific individual. That's one of the things. Another thing is about the messages. I think that currently saying that the computer calculated your score and based on that would be something that might be very problematic. So we're using the more personal approach, of which one of the people that you're familiar with is calling you and saying, hey, we look at your healthcare records and it seems as if we recommend you to do something, and to reduce the impact of saying it's some kind of a software or some kind of algorithm that was around that, but rather the algorithm is more for the decision makers. And then it should be translated into the clinical practice by someone that you're familiar with or someone who has the expertise to convince you to come to do your recommendation. And so those are a few of the things that we mentioned that we saw. Another thing that we saw that influenced the compliance is who's calling the patient, someone is familiar with or someone who is unfamiliar with. Because if it's a flu vaccination, then a nurse could call and it's okay. But if we're talking about screening, it might be that your a general practitioner should call you and say, hey, I see that you're not up to date with your screening. We recommend you doing that. So there's a lot of know-how that was collected and might be associated with each and every disease that we're trying to predict. But in a sense, moving into personalized recommendation, I think that's most of the important parts that we learned throughout our experience.
And about the stability of the models, we learned that first they are pretty stable in a way, so the performance does not deteriorate very fast. And even though the parameters of the population may change, and we keep some kind of maintenance routine of checking once in a while to see we don't know the correct label, of course, of the people that we label there, that we flag, but we can see the statistics of the scores. And we expect it to be stable in a way. And if we find some changes there, we have to find to what change in the population we have to attribute it. Sometimes the population gets older. Sometimes, I don't know, the smoking population, the smoking, the less people are smoking in this population. So we have to find some ways, in a way, in a blind test to make sure that the model is still effective. And we dedicate some efforts for this to make sure that model that was tested 2 years ago is still valid and still working properly.
Another safety net that we're using is that whenever you have an unscreened population, it's always tricky to identify what is the prevalence of a specific disease within that population. Because you know the incident rate, you can look at the SEER and you can see the incident rate of diseases, but unscreened population inherits higher compliance or higher incident, and the prevalence is much higher. So when we're doing our estimation and provide some kind of a overview to the customer, we're providing a very conservative approach based on incident rate and not based on the actual prevalence. And what we're seeing is that when we're collecting the real world evidence, the performance is much higher, just because we use a very conservative approach when we set the expectation with the customer. And I think it's important for us to come low and to be surprised for better performance.
And of course, we would also like to see the statistics of stages detected in these programs, because we expect the stages to get lower, especially when we introduce it into a virgin population that was never tested with this kind of machines. And we expect to have earlier stages to be detected more than before. And that's another assuring result.
Mhm. So Eran and Coby touched a little bit about the model performance and the drifts, if you will, the changes over time in the relationships between the variables and the data. Andre, can you tell us a little bit more about how you've seen that in real world? How do you detect this kind of drift? And what are some of the mitigation strategies you have used in these scenarios?
Of course. So first, I think it would be great to say that models don't drift on their own. There's nothing inside the model that degrades over time, like your car engine would degrade or an appliance would degrade. The data itself and the population changes over time. So to that extent, there are three main categories of drift. First is data drift, sometimes called covariate shift, which means that the distribution of the input features that go into the model from the patients change over time. And Eran touched upon this at the very beginning of our conversation when he mentioned that screening for lung cancer was recommended to be done 10 years earlier than initially. So you're going to have, after the new recommendation, you're going to have more patients being diagnosed at a younger age. So where a model that was trained before was looking at patients 50 and older because that was the screening recommendation, now a model would also believe in cancer being attainable at a younger age. So that's one type of drift that we have to monitor for and address it when recommendations change or when other features change. So one example would be the COVID-19 pandemic that drastically changed the respiratory status of many patients in the world, especially with long COVID. So we have to account for that with our models and continue to improve them when we measure a change in the input feature. And we have different methods to do this. One would be the CAS test or the population stability index. And the mitigation is very simple. We just retrain the model on the new feature set and we check if any feature importance has changed or if any features could be added to mitigate drift. The other type of drift is label drift, which is, or sometimes called a prior probability shift, which is the distribution of the target. So the lung cancer code in this case that we try to predict. And this could change for a variety of reasons. You could have new thresholds for what is defined a stage 2 cancer, let's say. Though that changes, we've been having the stage of cancer fairly set up for a number of years now. But for example, in the ICD-10 coding system, there is no discrimination between non-small cell lung cancer and small cell lung cancer, which are fairly distinct in their pathology. So a model does not have that level of discernment between the two types of cancer. So say in the next few years, we have an update of the coding system, then we can retrain the model and see how it performs for various pathologies of cancer. And the final type of drift is concept drift, and that is when the relationship between the input features and the target, the lung cancer code, change over time. So that would be an introduction of a new treatment that could create or prevent cancer genesis. Another factor that could be represented there is the incidence of smoking or programs for smoking cessation, which again could change how cancer is expressed in the features that the model looks for, which are blood labs and clinical variables. So with on a regular time basis, we could do a recalibration to check that the relationship between input and label has not changed, or if it has changed, we can recalibrate the model as we see fit. But as Coby and Eran said earlier, frozen models are great because we can check them over time and measure drift rather than continuous improvement models where it's very hard to measure drift when the model changes all the time. And also, we don't see as much drift in a period of 5 years, 5 to 10 years. So drift is natural, but we need to take it as it is. That is going to happen. But the time scale in which it happens for certain conditions like lung cancer is not that short. So it's great to have confidence in a great model and check it that it performs correctly rather than try to tune features every 3 months and eventually break it.
Makes sense. So given that things are moving, new things are happening, population dynamics are shifting, how would you measure, I'm assuming this is not a static thing, but how do you measure success of your algorithm? Whatever success may mean in this case, nobody wants to hear they have cancer, though it's probably better you know than you don't, right? But what are some of the benchmarks you use to evaluate your algorithms in the real world? Eran, how have you done this at EarlySign?
Right. So first, I think that Coby touched the point of which we are based on compliance. We can flag, but if no one comes, it means that we can't create any impact. So the higher compliance that we get, the better there is. I think there's going to be a quality index being introduced in 2025 associated with compliance rate of screening for lung cancer. So one of the things to measure ourselves is how much did we improve the compliance for the flagged individuals. Second thing, with regards to benchmark, there is the USPSTF criteria, but we're working within that, so we can show how much elevated within that population we can increase the yield, like 4 times higher or 6 times higher. We set ourselves to at least 2 times higher. I think that the clinical practice shows that we would have somewhere between 6 to 8 times higher elevated risk within the USPSTF criteria for the flagged population by using the model. So for us, it's always to show some kind of a significant improvement over existing methodologies in order to demonstrate what is the strength associated with running such models. So the benchmark would be either the USPSTF, it could be other risk scores such as the PLCO that we also demonstrated the ability to perform better and to flag younger population compared to the PLCO 2012 model. And it also was published. So in a sense, for us, having the best-in-class models being as a benchmark for us and to show a higher performance, this demonstrates the power of using such a tool. Another thing that we're having as an advantage is that we're having a dynamic model, which means it's being freezed, but your healthcare records are being constantly updated. And we are integrating those changes because we're providing within the model a trend over time. So any changes within your healthcare records could be represented or correlated to the score, the risk score that's being calculated for you. So this is one of the things that allow us to have a dynamic model that could be influenced by your current status compared to the previous one.
Makes sense. So given that your model has been around for a while, what is the impact you've seen so far out in the field? And what do you anticipate moving forward will be the impact on patient outcomes? And you mentioned compliance. We're trying to effect and increase the level of compliance, and especially healthcare costs as well. We talked a little bit about the financial benefits of this. How do you anticipate that playing out over time?
I think that clinical impact is going to be published in a manuscript in a few months, but we see the improvement in compliance. We see the improvement in the yield of the low dose CT with regards to significant finding associated. With regards to the budget impact, this is also a manuscript that currently is under review, but I would say insight that it shows the things that I mentioned with regards to the cost saving associated with running such model in very short turnaround time. And I think that the real world evidence support what we saw on retrospective validation. And in a sense, for us, it was an assurance that the model as being implemented and used in clinical pathway demonstrated what we previously published on retrospective validations.
Thank you for that. Before we get to the end, wanted to talk a little bit about the perceptions of AI. As you all know, very promising, but it's not without its challenges. You've talked a lot about the ways the data can be challenging when creating these models, and there's a very real potential for harm. And as far as providers and other folks are concerned as well, there are those who talk about AI taking jobs. There are others who are concerned about the level of human oversight, especially in these clinical decision-making processes that are powered by AI. So how do you view the role of AI in supporting rather than replacing clinicians? Coby, any thoughts on that?
Yes. Actually, the more impressive part of AI, which is the large language models and the generative models, are not in the play right now. Okay, the models we are discussing here as support tools do not replace the physician, and they are not doing the miracles that we see in the late developments of AI. Still, there is a lot that we can wait from this industry, but it is not there yet. The thing here that we are using a mature technology of AI, the part that is more traditional AI and not the developments of the recent years that is not mature yet. And we use it as a clinical support. It is not supposed to take any job from anybody, if not to add jobs to some people that are doing those screening. And about the prospect of the whole AI industry, I think it's too early to say, but I think that we will know to use it at least for good purpose like medicine and society. Of course, there is my main suspicion, my main reluctance from AI is when it is used for military reasons. And this is a different story that we are not in. We are in the good industry here, and I think for medicine it will only bring benefits.
Yeah, and I can break down the mysticism of our AI in the case of screening for lung cancer. People use algorithms implicitly in their mind to prioritize lung cancer screening. So everyone would screen a smoker for lung cancer versus a non-smoker. And then you can break it down and look at smoking history. When did that patient quit? If they quit, how long have they been smoking for? Those are common sense assumptions that are generally correct, which we can make in prioritizing screening. But we can only go as far in the numbers of variables we can check in our mind to do some sort of prioritization in screening. And the beauty of the AI system is that it does exactly that, but at a larger scale, with more computational power. An experienced oncologist would probably be able to do the exact same thing and look at the clinical variables, at the blood labs, and make a similar decision to the AI. But oncologists are not involved in screening for lung cancer. They are involved in diagnosing it after screening and treatment. So what the AI does is provide the ability for the person doing the screening to do it in a more robust way. So it's the exact same job, which previously was prioritized by smoking status, age, and a few other variables. Now it can be prioritized by more variables with a larger computational power behind it. So effectively, the job hasn't changed. No one has been replaced. We've just added an additional substrate of knowledge onto the delivery, the screening to patients with the highest risk.
If I may add, in a sense, our main challenge is the lack of resources. A patient sitting in front of a doctor has 10 minutes. The doctor has 10 minutes to talk to the patient, to decide what is what you would like to explore more. And what we're trying to give is some kind of an insight for that doctor. This individual has a specific condition you may consider. And we know that you can't run all the tests. We're trying to specify what is the most elevated risk that this individual might be associated with. And we're trying to provide the healthcare professionals some kind of a tool to spotlight things that we think are elevated. We're not saying other conditions are not there, but we're saying what we immediately see as the current status that need to further elaborate.
Sorry, Marilyn, I think you're muted.
Oh, I am muted. Thank you, Ben. Did you have something to add?
Yeah, I think the group has hit on all the important points. I think AI integration into healthcare is going to be more like computer-aided diagnostic rather than computer-only diagnostics. I think the human touch to care is not going away. I think also the human element of expert review and decision making is going to be the ultimate decision. And lastly, I'll just say, we talked a lot about AI as from a diagnostic point of view, but I believe what Andre and others were alluding to is that one added benefit is in addition to learning things that humans may have trouble learning from the complex data themselves, is just streamlining, right? A lot of it is making the healthcare process more efficient and more streamlined, which in and of itself can make it the overall benefit of the healthcare delivery. So I think the role of models in the delivery process are multifaceted, and I invite us to really consider the benefit across multiple of these dimensions.
Absolutely. Thanks for that, Ben. We've covered a lot of ground and we are getting to the end of our discussion. But before we close off, I would like to hear your thoughts about what comes next. Looking forward, where would you say we need to invest or research more to make a substantial impact in healthcare? Where do we need to place resources for advancing AI in early disease detection? Where in healthcare do you think is the most will get the most rewards, if you will?
Maybe I can just quickly start. Then would love to hear from the rest of the panel. I'll just speak very high level here, and I wish we had more time to go into specifics. But number one, just data collection and types of data that can be collected at more frequent intervals. I think that is going to be crucial for identification of patient state more accurately, but also for minute changes over time. And also, I think the need for this is probably longer term, but more randomized control trials. Of course, these are expensive. Of course, they're very hard to integrate, but I think that's where the field eventually needs to go. But in the meantime, from the pure model development and building process, I think a higher variety of data, the omics to the multimodal space at higher frequency would be a huge boon.
I would say that for me, I believe in a Kaizen, a continuous improvement of small steps. So I don't think that we should change the common practice of physician nowadays. We should be integrated into and provide some kind of a safety net for existing methodologies to start with until we create some kind of certainty of those tools and some kind of introduction of such. So I won't say that you should put all the eggs in one basket, but rather use that tools in a subset, a small subset, 5%, 10% of your population, just to see what the impact you're creating, just to be over existing methodologies and add-on and not to replace anything. And only after you position yourself, in a sense, you can explore into more powered decisions. So it should start by small steps, baby steps, to be introduced, to get the confidence from the healthcare professionals they can rely on when they're making the decision, and to do a rule-in approach. Don't say who doesn't have anything, because those models can miss cases. So just do a rule-in. Who is in elevated risk? The one that you didn't flag, that won't be considered as a low risk, but rather a general population that it was taken out of. And just do it first as a few first year to get acquainted and get the community being more clear about how it can support, and that they would also have their clinical evidence from their community, and only afterwards to move to the next steps of more integrated into the systems and more decision making, and even bigger share when you make those decisions. So I think it should be very light solution now that would be growing as time goes by.
I would like to be a little more optimistic and far-seeing. I think that AI will come also into the treatment part, and not only of the classification part and prediction of patient's condition. And the main, we heard about the Nobel Prize for Google for designing proteins and predicting folding of proteins. And this is going to make revolution in production of medical compounds and medicine. So not only will be able to predict the conditions, but we'll be able to treat them, and treat them personally according to the actual findings in the pathology that we are going to find. And so this will all be one system that will find the patient, characterize the patient, and treat the patient. And this will lead to a very great improvement in the results of medical profession.
Coby, if I may add to your words, I think that ever since we started, we never took a shortcut. We always created the sufficient clinical evidence to support. So I think, yes, we're going the direction you're mentioning, but it should be also backed up with some kind of clinical and financial references to support the process as we did so far, in order to make sure the decision makers would be very convinced about the potential advantage of using those, either on clinical aspect of identifying individuals in early stages, but also on financial aspects of having a cost saving associated with using those tools.
We are not in any argument. We are just looking at different time steps.
Agree.
And we hope that our operations research on AI solutions would help clinical staff operate at the top of their license, which is delivering care. And they trust in us to streamline processes that could be streamlined through AI and machine learning, which is identifying risks, streamlining screening, identifying risk of mortality or complications, to prioritize treatment, to aid in treatment selection. Our goal is to add knowledge and help people make the best decision that they could with the limited information that they have. So yeah, we hope that by our process of building responsible, transparent, and useful AI, we can help the clinical professional in that way.
Absolutely. Thanks so much for sharing your experience and also for all the work you do in this space. It's really exciting to see some of the advances in AI, especially with healthcare. Cancer is really personal to a lot of people, like I mentioned. And so each and every one of you is contributing to what I hope would be a better world at some point. Maybe we hope even a cancer-free world. Hopefully, we'll all live to see that day. Thank you so much for your insights today. And I appreciate your engagement in these conversations. We look forward to keeping the conversation going as we all continue on this journey. Thanks again and take care.
Thank
Thank
you,
you.
Eran.